Morena, welcome and thank you for joining us at our Hospice West Auckland webinar. Now, before we begin, just some housekeeping rules. First of all, hope you can see me and hear me okay. Just ensure you use the Q&A function for any questions you have for myself and for the panel, and use the chat function for any non-content related questions. Also note that this webinar is being recorded. We will start off with our Hospice West karakia. Turuki whakataha, turuki whakataha, homie, huie, tai kie. Hello everyone, my name is Carmen. I am a pharmacist here at Hospice West Auckland, and today I will be talking about the fundamentals of subcutaneous prescribing in palliative care. I have only really been in the palliative setting for the last 8 months. My pharmacy background has really always mainly been in a community and hospital setting, and never in a million years have I ever thought I would be working in palliative care. It wasn't until May last year that I had to suddenly become a carer to an immediate family member. He was given 2 months prognosis to live from a brain tumor. There was only palliative chemo and best supportive care that we could have really done for him. We had him for another 8 months and off he went on his own journey. So palliative care has since been something that I hold very close and very dear to my heart. It is an honor and privilege to be able to work as a team here at Hospice West Auckland, being given this platform to give back to the community. Joining me today are Shino and Sophie, pharmacists from All Seasons Pharmacy, who we Hospice West Auckland work with a lot on a daily basis. They will be sharing with us on practicalities and the how-tos for prescribing and dispensing, which I know is a hot topic amongst the audience, so stay tuned. Of course, we also have Dr. Oleg, palliative care specialist, who will be monitoring the Q&A functions. This is a brief overview of what will be covered today in the webinar. We will first talk about what is subcutaneous prescribing in palliative care, what is a syringe driver, and the rationale of it. Then we will talk about the considerations when it comes to prescribing subcutaneous medicines, such as how we convert from one opioid to another, how compatible the medicines are in the syringe, the volume, the diluent, and of course, real-life prescription examples of the how-tos and a brief overview of Emergency Medication Directive, or EMD as a short form. Right, hope everyone is still awake after that lengthy introduction. Let's start off with a poll to get everyone's engagement up. First poll of the day. Are you familiar with syringe driver and pre-filled subcutaneous medicines? Very familiar, familiar, somewhat familiar, not familiar, or not applicable in my role. I will give everyone about 30 to 40 seconds to get your answers in. Let's do maybe another 10 more seconds to get your answers in if you haven't already done so. Right, should we have the poll results out? So we've got 41% that's very familiar, 35 familiar, and 19% somewhat familiar. That's very interesting to see. Looks like syringe driver and pre-filled subcutaneous medicines are something that the audiences are very familiar of. This makes me so delighted to have you tuning into this webinar on a Wednesday early morning. I do hope, though, everyone here gets some value out of this talk today. So let's start with the what. What is a subcutaneous medicine? Subcutaneous medicines refers to any medication that is administered into the subcutaneous layer of the tissue, which lies just beneath the skin. The drugs are delivered into the subcutaneous tissue using a needle and syringe, which can be in the form of a syringe driver for continuous infusion or a pre-filled syringe, as you can see from the picture on the right. This route of administration is common and an effective approach in palliative care. What is a syringe driver? The syringe driver is the one on the left. It is a small battery-powered device that holds a syringe with medication. This device usually delivers the medication over a selected time period, usually 24 hours, and the medicines are drawn up into the syringe that is then attached to the driver, which is set to move the plunger of the syringe forward at an accurately controlled rate. This particular syringe driver that you can see on the left is called a Nikki T34 syringe driver, and it's used widely in the community and also in the hospital. On the right is a pre-filled syringe. This syringe comes preloaded with a specific dosage of medications, which can be used to help manage sudden, intense symptoms that break through. So these symptoms can include severe pain, anxiety, breathlessness, or nausea that occurs unexpectedly or rapidly that increases in intensity. Breakthrough symptoms often require prompt and effective intervention to maintain the patient's comfort. That's when these pre-filled syringes come into place. For several reasons, one is they allow for quick administration of medication without the need to measure it up and draw up the doses. So it is very important to have that quick response when a patient experiences a sudden escalation of symptoms. They're also really easy to use because they're convenient for both healthcare providers and caregivers, where you could just give it straight up because it's all pre-filled and calculated. So that also ensures accuracy. And these syringes are portable as well, can be easily kept at home, ensuring they're readily available when needed. So in practice, you'll see that the medication in a pre-filled syringe is often administered by an existing cannula when the syringe driver is initiated. And you'll see that the combination of syringe driver and pre-filled syringe are often seen as it allows for that continuous administration of medications and managing chronic symptoms that do fluctuate over time. And when is a syringe driver appropriate, you might ask? It's when oral route is no longer available. So we have decreased or compromised swallow either from a disease process or decreasing consciousness, when absorption from the gut is compromised, and when symptoms are difficult to manage in other ways. There are many benefits to a syringe driver. It's quite a wordy slide here, so I'll just read to it. Benefits to syringe driver when there's uncertainty about oral bioavailability. Could be ascites, etc. Also, it helps with controlling other medication management factors such as compliance. So as we said that we could put quite a bit of medications in the syringe driver, it helps with taking out the unnecessary administration of oral intakes with different medication that does different things, which brings me to the next point that more than one drug can be given at the same time, so multiple different symptoms can be managed simultaneously. We can also avoid the peaks and the troughs of drug delivery as it gives that continuous 24 hours relief. And this in turn help elevates the patient's well-being so you don't have repeated injections that you got to keep giving, and it allows mobility and independence. Disadvantages of a syringe driver is also very important to know. It's our responsibility to be able to articulate the advantages and disadvantages so patients and whānau could be empowered in their decision making. Disadvantages is because it's pre-filled, preloaded. Medicine requirements has to be anticipated for 24 hours period. And then there's a little bit more of a planning and logistics things where you have to write a script, get the pharmacy to dispense, get the whānau to pick it up or get it delivered. So it may result in loss of flexibility when it comes to dosing. You also may require PRN medications at initial syringe driver setup while we're waiting for that medications and that syringe driver to reach peak plasma concentration. This could take anywhere from 2 to 4 hours, so that there will be some education that will have to go into it. As you know, with everything that goes under the skin, you might have local reactions such as pain, inflammation, or infection that can cause discomfort as well. Initiating use of a syringe driver in a patient during palliative care may represent a significant and unwelcome milestone for the patient and their whānau, because the syringe drivers are often required and associated that a patient is close to death. And the goals of administering medicines via syringe driver really needs to be discussed with the patient and family and any concerns addressed. So syringe driver simply provides an alternative route for the administration of medicines. For example, a patient with severe nausea, vomiting, that temporarily couldn't take any oral intake and oral medicines may need a syringe driver to get on top of symptom control. And people do go off syringe driver once the symptoms are controlled and when oral intake is restored. So it is therefore our responsibility to ensure that patient and whānau are educated on the rationale of the intention behind why we do what we do, as this also helps to shape their overall experience with us as a healthcare professional in the healthcare system. One thing that I always keep in mind is something called ADR. So A for acknowledge, D for disassociate, and R for reposition. We address any fears or anxieties or past experience they have had with syringe drivers, reassure them that syringe drivers do not always mean that death is imminent, and explain that it is just a means to get the medicines in the bloodstream to get symptoms controlled. And by doing that, I think we could take out so much stigma of how they view syringe driver as the final step before death, or they may get stuck on a syringe driver. Obviously, there's that initial cost on infusion devices as well, and the training of the staff and the patient, making sure that they're educated on on the logistics of it. Hospice or district nursing services can provide equipment and certified staff who can work with GPs. Patients and partners are available in the community. So many patients may also be under the care of a palliative care physician, and residential aged care facilities also have syringe drivers on site and staff trained in their use. So primary care providers, if you're thinking that someone may benefit from a syringe driver, you do have quite a bit of support out there in the community. Okay, so main symptoms that we see a lot in palliative care are pain, nausea, vomiting, delirium, restlessness, agitation, breathlessness, respiratory tract secretions, and seizure control. There are a lot of medicines that can be used to control these symptoms, and they can be given subcutaneously. So for pain, we largely manage this with opioids and syringe drivers. Morphine is generally the first-line opioid for pain and palliative care, as one, it is the most extensively studied one, second, it's widely available, and third, is so commonly used. Oxycodone is a second-line treatment option for patients unable to tolerate morphine, or they have mild to moderate impaired renal function, as it is not as extensively renally metabolized as morphine. If a patient has a significant renal impairment, oxycodone may not be a suitable treatment because the active metabolite accumulates. There is also the possibility of increased blood concentration of oxycodone, causing an increased clinical effect and risk of toxicity if oxycodone is taken in conjunction with some CYP metabolizing enzyme inhibitors. Fentanyl, another safe option for patients with significant renal impairment. But the use of fentanyl can be problematic in the community setting, especially in subcutaneous because it's short acting, so you may require frequent injections. A syringe driver, though, may be beneficial for someone that may benefit from fentanyl. Methadone is another alternative option. It is a difficult opioid to titrate though due to its wide variation and individual patient response, and it's also its long half-life, but it's super useful for those that have difficulty in pain management with the standard opioids or those with renal failure. This slides could be a refresher course to most or some of you. Now, the cause of nausea and vomiting in the last days of life are often multifactorial. Regular reviews required to assess for severity of and any contributing factors. If we decide that pharmacological treatment is required, subcutaneous haloperidol is normally the preferred first-line option in patients with no contraindications. The general rule of thumb is that when we prescribe antiemetics, we increase the dose if there is a small but insufficient improvement in symptoms. Second is we establish regular dosing early to appropriately manage the symptoms. And third is we switch to an alternative antiemetic if there is no response to treatment. Levomethomazine is the next option for patients with persistent nausea and vomiting, despite maximum recommended doses of first-line antiemetics, though it is drowsy, so patient may experience sedation at a very low dose. And occasionally, a combination of antiemetic medicines may be required to provide the patient sufficient symptom relief in the last days of life. Then we've also got haloperidol, levomethomazine, and midazolam for delirium, restlessness, and agitation. And for breathlessness, we normally use opioids and also benzodiazepines to help relax the muscles. Whoops. Oh no, where am I? To help relax the muscles because that's also very commonly having anxiety associated with breathlessness. Now, the respiratory tract secretions or the death rattle refers to the noisy, rattling breathing that occurs in some patients during the final stages of life. It is generally not painful or distressing to the patient, but it could be quite distressing to the families. And the sound is caused by the accumulation of saliva and other secretions in the throat and upper airways, which the patient can no longer clear due to weakness or unconsciousness. So to help with our families that are very distressed, we can use hyacinth butylbromide, subcutaneous or in syringe driver to help dry up that excess salivation to get the death rattle out. And note to not get it confused with hyacinth hydrobromide. So it's a different type of salt form. The hydrobromide could cross the blood-brain barrier, causing central side effects such as sedation, confusion, or delirium, which may not be something that we like at the end of life. And for seizure management, we use midazolam and levetiracetam. I just want to take this time and space to thank Emma Kirkier from Harbour Hospice for pushing levetiracetam out to Pharmac to get that funded in the palliative setting. Previous to that, I had to apply for multiple NPPAs to get levetiracetam used in our patient demographic. So thank you for taking that paperwork load out of me. So just a chart to show the commonly used drugs, the doses, and the indications for that, which was all covered in that very wordy slides previously. When prescribing, we want to consider the patient's medicine requirements for 24 hours. So first, we want to convert the patient's previous 24-hour oral medicine requirements, so that's including the regular and the as-needed doses, to get the equivalent subcutaneous dose. Using the opioid conversion chart, we determine the ratio. So for example, someone is on 100 milligrams of total morphine oral daily dose. We can start them on 50 milligrams subcutaneous morphine over that 24 hours, as the ratio from oral morphine to subcut morphine is 2 to 1. The doses that may be required for breakthrough symptoms is approximately 1/6 of the total daily opioid dose. There are many conversion charts out there. There's even conversion calculators online. And this particular one is a Mercy Hospice chart that I know Dr. Oleg likes to refer to. And when more than one medicine is used in an infusion solution to put in that syringe driver, remember we talked that we can have 3, sometimes up to 4, there is a risk that these medications may not be compatible, either chemically or physically. And the higher the number of medications in the solution is, the more risk of problems with the combinations. Physical incompatibility usually results in changes in the solution that can be observed as discoloration, clouding, or precipitation. Hence, it is important to refer to a compatibility chart as what you can see here on this slide. The choice of diluent for the infusion solution do vary according to local guidelines, as there is evidence for and against the 2 most commonly used diluents, which are water for injection and sodium chloride. This is a new compatibility chart that's been released in January 2024. It includes levetiracetam and famotidine, and this chart can be found in hospice.org.nz, freely available and accessible for your resource. With regards to diluent, this update reflects the preference for sodium chloride wherever possible. And this is because sodium chloride is isotonic, therefore less irritating to subcutaneous tissue compared to water for injection, which is hypotonic. We also talk about volume. So when it comes to prescribing, we need to consider how much a syringe driver could hold in regards to the stock volume. So it usually holds 20 ml, 30 ml, 50 ml syringe, but we don't pack the syringe up to max. 50 ml syringe can really hold about 34 ml maximum. So when prescribing something of a high volume like furosemide or let's say levetiracetam, sometimes we need to go up to a 50 ml syringe or sometimes even 2 different syringe drivers running at the same time to get the 24 hours dose into the patient. For the audiences that are more visually driven, I have included these resources that I refer to quite often in my daily practice. The Palliative Care Handbook, the green one, especially is my holy Bible. It pretty much has everything you need to know about medications used in palliative care. I understand that palliative care might not be something some of you deal with often in your day-to-day work. You might come across 1 or 2 patients a month or 1 or 2 patients a week, and it is okay. We certainly don't expect everyone to know everything, but if there's anything I would like you to know today is to know where to go for resources and the answers and who to go to for help as well. And more resources listed here on this slide. So we're almost halfway through this webinar. How is everyone feeling? Hope you guys are still here and still awake. Shall we pull up a second poll question to get some engagement up? So second poll, can all pharmacies do syringe driver and pre-filled subcutaneous medicine dispensing? True or false? We'll have about another 30 seconds to 40 seconds for everyone to put their answers in, and then we can come back with a poll result. Ten more seconds if you haven't already managed to put your answers in. Okay, let's have a look at the poll results, eh? 90% says not all pharmacies can dispense syringe driver and pre-filled subcutaneous medicines. And yes, you are completely right. That brings me to my next slide. For those who say yes, the answer is no. And the reason why is because for pharmacies to dispense syringe driver and pre-filled syringes, they first need to obtain a dispensing contract from the DHB. And that's because there's extra accreditation for pharmacists to be trained in it and for pharmacies to obtain the still air boxes to do aseptic compounding. In my short tenure here at Hospice West, I have been approached by a few community pharmacies wanting to extend their service to include this. My general advice is to get in touch with your DHB portfolio manager to discuss about contracts. For those in practice, the first link on this slide is a database that you can tap into of all the pharmacies in the Auckland region who does syringe drivers. Now, I just wanted to highlight that even if a pharmacy is listed on that database, they're accredited to do aseptic compounding, it really still depends on having a trained pharmacist and staff to be on site. That can be particularly tricky, especially during the holiday seasons when regular staff are away or when the pharmacy is being managed by locum that's not trained in that aspect. So it's just some practical points for you to think about when prescribing subcut meds for patients who are traveling or just in general the holiday seasons. And for those that are interested in learning more about syringe driver, the third link is a free e-learning site for your information. So let's talk about practicalities, which is something I really look forward to. Introducing Shino and Sophie, who are so thankful for their presence today. Ladies, the floor is all yours.
Thank you, Carmen. Morning, everyone. I'm Shino. Sophie and I will be talking about what we do in the palliative care space in our pharmacy. Firstly, it's important to acknowledge that palliative care service provision has changed or evolved greatly over the last decade. Historically, community pharmacy was involved mainly in aseptic dispensing, i.e. medicine supply. These days, our role extends a lot beyond medicine production. We are involved in aseptic dispensing plus providing patient support, which could be trying to streamline and simplify the patient journey so the patient or family is not caught up running out of repeats and arranging prescriptions. Patients are under palliative care for a longer period of time than what we were seeing before. To provide some context, we have had at least 5 patients in the last 12 months who have been on syringes for over 6 months. It is common for patients to be cared for by hospice staff, hospital staff, and the GP care team at some point in their journey. This highlights the importance of forming good relationships with families, prescribers, hospice nurses, carers, etc. A quick overview of what happens when we receive a prescription at our pharmacy. We usually liaise with prescribers or nurses. If it's a hospital discharge, we are interested to know the changeover time, whether that person has already got one syringe attached, and when the next changeover time would be. The quantity of pre-fills expected to be used, so we can give an appropriate supply. For example, if it's weekend cover. Key contact, so if this would be a family member who would be liaising, like pickup, or just the person, a family member who would be able to let us know how they're doing. Time frame for the medicines to be ready by, usually the hospital pharmacist or one of the nurses or prescribers would let us know when the discharge would be happening. We're interested in the collection time, or if the family or the hospice nurse is collecting their medicines, or whether the pharmacy is delivering. We check in during usage. This would be, for example, pre-fill usage during follow-up. And this is how we determine how we would supply the next lot of medicines. We provide an information sheet to patients, and with these, so that's an example of the sheet that we provide to patients when they're first being started on syringes. It highlights a few important points, like remembering to keep the medicines in the fridge, noting the expiries, and noting the use, the frequency of use. Next, Sophie is going to talk a little bit about some practical points to ensure that the whole journey occurs smoothly.
Lovely. Thank you, Sheena. And thank you again to Hospice West Auckland for having us here today. This is a really cool thing to be part of. So what does ensure a smooth journey? So firstly, and arguably most importantly, once a script has been sent through to us, it's really, really important that someone gets in contact with us, just so we can make sure we've got the prescription, we can ask any questions that we have, and ultimately we can get the ball rolling with production and therefore get a product to the family as quickly as possible. Worst case scenario is when a family shows up 5 minutes before we're closing, we can't find the prescription, it's at a different pharmacy, it's in the ether of the internet or the ether of a junk box. Can be quite a distressing situation. Likewise, we also really appreciate being updated if the patient has stopped syringes for whatever reason. Perhaps they've been admitted or even deceased. We have had more than one occasion, despite our best efforts, where we have made syringes for an admitted or deceased patient. And I'm sure we can all really appreciate that in this day and age, it's a really big waste of both time, but also resources. We often can't then use those syringes for another patient. Clear and accurate prescriptions. I'm going to talk about this a bit more in the coming slides and have some examples that we'll talk through as well. But this is about how a clear prescription can really help streamline the process and get our product, our syringes, to that family, to that patient faster. We see a lot of problems with prescriptions crop up at transition points. So when that patient goes hospital to hospice, hospice to GP, GP to rest home, etc., seems to be a bit of a danger zone with errors on prescriptions or problems with prescription, and that's obviously a time that we're trying to keep things going as smoothly as possible. Timely repeat prescriptions. So once the patient is up and running on prescriptions, up and running on syringes, we're always conscious of having a supply of repeats or a prescription on a hold for that patient, so their supply isn't disrupted, keeping in mind that their usage can change quite quickly. We try as a service provider to take away that burden of needing to arrange new prescriptions. So we're avoiding a scenario where a patient or family calls us saying they need an extra supply of their morphine prefills, and all we can say is that we don't have a script on hand. So we try and take on that role. But it's a really, really fine line. We can't request prescriptions too early because things might change, controlled drug scripts expire, but we also can't leave it till 2 hours before they need those syringes. If I was to put a time frame on it, I would say if we are requesting a prescription from a practice or a prescriber, we ideally need it back to us same day. And I wanted to mention that because I realized that time frame can fall out of a practice's usual prescription request time. And the point there is that sometimes these palliative patients, they do need a sort of extra level of service, or they do need things to be turned around quite quickly. We've recently set up a bulk list, a system where we send a bulk list of requests to Hospice West Auckland once a week, and that's working really well. That creates a good paper trail of what scripts have been requested. Cool, so let's bring up another poll before we go into some examples of prescriptions. Our next poll, how confident are you with writing or deciphering prescriptions for syringe driver and pre-filled subcut medicine? Give you a minute or so to have a look at that one. Cool, thank you. Just a second or so more to put your answers in for that. Okay, just having a look now at these results. Okay, so a real mix, leading more towards those middle sort of answers, somewhat confident, confident, and not a lot of people out there who are feeling really confident. So I think that's a really clear reflection of what we see in practice, and that's why today is so great, because now we can go into some examples, and hopefully after today some people might be feeling a little bit more confident or know where they can go for help with deciphering or prescribing these medicines. Ooh. Oh, lovely. Okay, so let's talk through some examples. So this first example here, and this example talks about prescribing in ampules, which is probably one of the more common problems that we see crop up. I just wanted to mention though, I realize there might be centres or pharmacies out there that do actually supply just the ampule for nurses to make up the syringes. That is the system that runs in the area. So in that situation, a prescription like this might be totally fine. But all of the examples that I'm sharing today, these are prescriptions that are intended to be made up as pre-filled syringes. So let's talk about this a bit more. Prescribing in ampules. So you can see that here the quantity has been listed as an ampule. The problem with that is that it's really ambiguous as to what the intention is in regards to quantity, so how many to supply. You can see, I completely understand that some systems, some software programs out there aren't overly friendly when it comes to prescribing syringes. We totally understand that. And so we do encourage doing exactly what this prescriber's done here. If you are forced to do certain things that lead to ambiguous prescriptions, feel free to write something additional. We do read it all, and things like this can be really helpful to help understand exactly what you're meaning. To elaborate a bit more on why this can be a bit confusing, this is if this was being made into pre-filled syringes, each 10 milligram ampule can provide 4 2.5 milligram doses, and therefore this prescription actually allows for up to 80 pre-filled syringes to be made. Obviously, we would not provide 80 in one go, but I just want to show that that's actually how this is interpreted when we're making pre-fills. So communication about quantities is really important. These examples here, supply 9 syringes, or this one here that is showing prescribing in days, also works really well. Even better, maximums. Maximums is really, really helpful because it can limit how many we provide. And it also helps to provide a trigger point as to when a family should be seeking a review. or getting some additional help, because if a patient is really sucking through pre-fills, then obviously that can be a really great time to either put them on a driver or adjust a driver with higher doses, and ultimately that leads to a more comfortable patient. Okay, next example here. Midazolam here, this script is a bit of a merger, a bit of a combo of a pre-fill and a driver on one line, 2.5 milligrams every hour, max 6 doses in a syringe driver. So they've sort of popped the PRN and the driver prescription on one line. Obviously not ideal, as Carmen showed up with the pictures earlier. Those are two separate items. They do need to be prescribed separately. And we've got some examples here of what a really nice pre-fill and then a driver prescription looks like. So we've got a nice clear frequency, number to supply, indication, and for our driver, nice bolding there that this one is intended for a driver. And a driver can only ever have a set dose in it. Again, you can see on that example here, we're seeing prescribing in vials, and as talked about earlier, it's not ideal, it's a bit ambiguous. I also wanted to point out here, this is a question that we often get is, do I need to prescribe every single ingredient in the syringe driver individually? Yes, you do. We sometimes see it in hospital that just one item will be prescribed, and then in the instructions or in the text, it will say in a driver with haloperidol, with morphine, and sometimes doses are left off. So yes, we do. For clarity, it is best practice to prescribe every item that is in the driver as separate prescription items. You do not need to prescribe the diluent, and you do not need to prescribe the volume. We sort that out at our end. Okay. Just some final quick examples here. This one shows a dose range being prescribed for a driver. Just as mentioned before, we can't put a range in a driver. A driver is a set amount infused over 24 hours. And this final example here is showing prescribing in mils. This is also really is not ideal. It can be a bit confusing. For example, if this is going onto a Medimap chart, but we have used a different size vial to make these, and therefore the mils is different than the prescription to the final product, can create a bit of confusion. So that's something else we don't really encourage. So if I was to give 3 sort of takeaway points or 3 pieces of advice if you are new to prescribing or new to interpreting these prescriptions, is if you're trying to get a message across to us or trying to make something a bit clearer, feel free to use the free text, either in the instructions part or whatever on your prescription software. We do read it, and it can be really helpful, because I do realize there are limitations within what software will allow you to write. If a patient is transitioning from, say, hospice to GP to rest home, etc., any scenario where the patient has already been on syringes in the community, those instructions, those labels that have been generated by the pharmacy are viewable on TestSafe, like any other medication dispensed in a community pharmacy. So that can be a really great starting point if there's any confusion on what patient the dose is on, what drugs are together in the driver, etc. Our existing directions are viewable on TestSafe under the patient's name. And finally, feel free to call us, even if the prescription isn't ultimately going to come to us. We love helping in this space. We're happy to help. We much prefer a phone call to sort through any problems, questions, rather than leaving it to the point that we're trying to get in touch with someone after a practice is closed, etc., etc. Cool. So that was the main things from me, and then I am handing back to Carmen to talk about EMDs.
Thank you, Sheena and Sophie. I found the real-life examples really interesting, so thank you for sharing that. Now, we still have some time left, and I wanted to briefly introduce our Emergency Medication Directive, EMD. Some of you may or may not have heard of it. EMD was basically a project that was driven by Dr. Oleg last year in Hospice West Auckland to help improve patient outcomes. It is a new process that replaced our ambulance letters for patients. Now, prior to starting at Hospice West, I've never heard of EMD, never seen that in community or um, my locuming sort of journey. So just thought that some of you may be interested in hearing about this. The rationale of implementing EMD in all our hospice patients here is to ensure that the best response is given in the after hours period. It's normally an opt-out rather than an opt-in process, which means that all our hospice patients would have them. And the ones that are excluded from an EMD are patients with low medication management capacity, risk of opioid diversion identified, patient refused for any reason at all, and those that are in aged residential care. As we practice anticipatory prescribing in palliative care, each patient gets a medication kit that comprises of an opioid for pain relief or shortness of breath, an anxiolytic, and an antiemetic. So my next slide will show you a photo of how the kit looks like. So you can see it's an opioid, antiemetic, and an anxiolytic. So these EMDs, they are stored in a safe place in our patient's home, and in an acute event, it can be used by paramedics or hospice doctors for symptom management. Here at Hospice West, these get reviewed approximately every 6 weeks to determine whether the medications are still clinically appropriate for this patient. So whether they have any deterioration in renal function that might need to change the opioid, or have they moved on to a different opioid, and we just use that EMD to align with their current opioid regime. When community pharmacies get the EMD prescription, this prescription here will be accompanied by this EMD letter. And this EMD letter basically states the patient details, the specific medication, and its doses for the EMD pack. So please do double check and cross check that it does match with the prescription. Patients also get educated about EMD during their initial assessment with our hospice nurses. They get given an information sheet about what it is, and they can go ahead and make an informed choice whether they'd like to proceed with it. We also like to include the whānaus or the people that live with them as well. So during emergency, a paramedic or hospice doctor comes, we know exactly where the EMD is, and we can use that if needed. So that is it about EMD. This takes us to the end of my talk. Now, my take-home messages are ensuring that, one, we take the time to explain the rationale of a syringe driver and subcutaneous use of medicine in palliative care to patients and their whānau. ADR, so acknowledge, disassociate, and reposition if needed, as what we do today is the foundation of tomorrow's work. Also, I do understand that there's a lot of considerations when it comes to prescribing. Palliative care, palliative patient may not be something that you come across on a day-to-day basis, and that's okay. Most important thing is know where to find your resources and utilize a multidisciplinary team for their expertise. No one is expected to know everything, and everyone has their value to bring to the table. This brings us to our Q&A. I will now stop sharing my screen and bring forward my panelists, Shino and Sophie from All Seasons Pharmacy and Dr. Oleg.
Lovely. Thank you, Carmen, Sophie, and Chanel, for that detailed update in our current clinical practice. So let's have a look at the question. So the first question we have from the audience is, why are pre-made syringes kept in the fridge? Might pass that on to Chanel and Sophie to answer.
Yeah, cool. Thank you for that question. It's actually quite a good question because it's one of these things that you've done for forever. And because you've done it for forever, you don't actually necessarily question it. But at the most basic level, the answer to that is to reduce bacterial growth. So reducing, keeping them in the fridge, just like we keep food in the fridge, reduces that chance of bacterial growth, therefore in the hopes of keeping our product cleaner and sterile for longer. In the background, there is a lot of work going on in regards to syringe stability, sterility, and we're hoping that we get some updated studies on things exactly like that, ideal temperature for storage, etc. It might even be different for different drugs, but the basic answer to that is to reduce bacterial growth. Shem, anything to add?
Probably just an acknowledgement. We know that in other areas we all work differently, and I think in other areas, in New Zealand, if there are some medicines in the driver which are not refrigerated, they don't refrigerate the final product. For example, they refrigerate famotidine containing syringe drivers only, but not the others. So we are aware of some variation across the country.
And also to add on to that, it is a bit of a contentious issue, but also the length that the syringe driver and the PRNs are viable for after they've been dispensed. Did you guys want to talk around that as well? Because I think there's some differences in practice that exists across the region.
Yeah, I think the current almost published best practice is 72 hours for both a pre-fill and a driver. Where the differing factors come into that is 72 hours is not always practical. It cuts it very fine over a weekend. At our pharmacy, we choose to do 4 days for both our pre-fills and our drivers, and that gives us lovely time to get over a weekend with a little bit of buffer. That is sort of based on experience and trying to make the journey as smooth and easy for a family as possible. And in the background, we're almost collecting our own anecdotal data and evidence. We don't seem to have problems with a 4-day expiry. We've sort of fallen to a 2 dispensings per week schedule, which works really well. So I think it's a bit of the application of the expiry date is a merge of both the evidence, which, like I said, is whirring away in the background, where we know there's studies going on right now that will hopefully give us even better data on sterility and what's practical and logistical for families during this time and journey for them.
Thank you, Sophie.
I think just to add to that, especially if it's a long weekend, and if everybody or 3 or 4 patients were due on Tuesday morning first thing, making it a 4-day expiry means that we can get on to getting the medicines ready in the morning, and they're all kind of the changeover time would be in the afternoon. So kind of works practically just from a work point of view, just prioritizing the workload.
Great. Thank you, Chanel. So another question, do you mix drugs in pre-filled syringes that are not for a driver? Can I get Carmen to comment on that?
Thank you, Kirsten. I thought about that question when I was showering last night. Oh, I've never seen drugs in pre-filled syringes. Why do we not do it? I think it's more about the stability than anything. So when we mix medications, we talk about stability and sterility. So when all seasons talk about, that 72 hours or that 4 days expiry, it's more about around the sterility side of things. In terms of pre-filled syringes, subcutaneous, you could really just do an amount of about 2 mils, because anything that's a bit more than 2 mils is very uncomfortable and irritated to the subcutaneous skin. So you got to think about the volume if you're mixing 2 different drugs in a pre-filled syringe, giving in a large volume as a bolus dose. That's 1, so volume and patient experience. And 2 is the stability. So we do know that they are stable and they are sterile in the syringe driver, but these are usually mixed with diluents to help with that as well. So yeah, no.
No, I absolutely agree with that, Carmen. And I guess to add to that as well, therapeutically, when you're targeting a particular symptom, you really want to use a single agent as well, because if you use 2 agents at the same time, there can be a little bit of uncertainty in terms of which one is more predominantly effective. You may well learn through experience that you need both agents, for example, an opioid and a benzo at the same time. But, we would definitely encourage, even in that situation, to administer them separately as well. Moving on. So next question is, do we need to return unused pre-filled syringes back to pharmacy, i.e. if the patient's passed away? Can I get Chanel and Sophie to answer that for us?
Yes, another great question. And yes, absolutely. We do encourage them to be returned. A large number of them are controlled drugs, and we definitely don't want those ending up where they shouldn't be. Returning of syringes is also really helpful to gauge usage. So as mentioned, we just talked about expiry dates. So we actually want any syringes that have gone beyond their expiry date returned back to us. It stops and muddle up where those might be used. And if we're seeing 12 morphine prefills come back to us every single time, even despite what a family might be saying about usage, it's there clear in front of us that maybe they're not being used. Yes, please return them to us. It's really beneficial.
Great.
So in that case, we would make less, or maybe we'd make 3 prefills just for the weekend cover, so they have something if they need, but we wouldn't give that quantity. So we just adjust the next supply based on use need.
We also dispose correctly in like a yellow biohazard bag. We remove any sharps, any contamination, anything that looks a bit icky. So the actual disposal is managed as medical waste in a pharmacy.
And
Well,
I
that's
think,
great. Sorry,
and I
no,
think
you
that
go.
Yeah, and I think that really helps to close the loop as well too, because the pharmacy is a key milestone for us to supply medications to patients. And sometimes I feel pharmacies is kind of at the end of the chain where they don't find out what's happened. So returning it kind of close that loop, say that, okay, hey, we've done what we can and patient unfortunately passed away. And I also
Sorry, also really interesting is we do eyeball them a little bit, and particularly drivers. It's really interesting to see if they're looking a bit cloudy or anything like that, any problems, any cracks. And yeah, it's a good way to just see what do they look like when they come back 10 days later.
Yeah. Do you, just out of curiosity, have like a lab that you normally send some really expired syringe drivers over to check for any microbial growth as part of maybe like a quality audit feedback, or
Yeah.
if there's an option to do that?
Yeah, we do that once a year, and I think we can do it as many times as we like, really. And they check for sterility and they give a report back. And we usually draw up sodium chloride and send it off. That's for Auckland.
So there are, there is official sort of rules that we abide by for audit purposes in regards to checking our production technique, and therefore that the product is sterile, and which is what we send away and get checked. I am aware though that there's other pharmacies out there, and I think this is a really great process. They actually send to a lab a syringe that has been returned by a family to get checked as well, and often those are coming back still sterile as well.
And I was just going to comment as well that it's great that you guys have the discretion to dispense how many pre-filled you feel is appropriate, as opposed to just simply dispensing up to the prescription maximum. So that's good to know that you guys have that ability to do so. So moving on, where can we go for further syringe driver training? Can I ask Carmen if you've got any thoughts about that?
Yeah. Been asked that question a lot in my short tenure here. So first of all, if you do want to get your pharmacy sign up, then you have to get a contract, which is out of my control. That's your DHB portfolio manager. If you do have a contract, you're wanting to get your staff trained up in it. I believe, Sheena, so if you correct me if I'm wrong, you do it through University of Auckland, isn't it? And there is a course called Active. I can't remember what it stands for, but it should be freely available online that you could search it up. And if you're just interested in palliative care in general, no contract, or like basically you're not doing it for the pharmacy business or anything, just for your personal interest, I'm glad you asked, because save the date, 19th of September, which is a Thursday, Hospice West Auckland is thinking of organizing a networking event in the palliative setting. So pharmacists the main demographic will be community pharmacists and some hospital pharmacists as well. So come around, have some kai, meet us in the space, and we'll have some speakers line up as well to keep your interest up. And also, one of the slides that I shared before that had a hospice Waikato link. That is one of the training that is really accessible as well if you're just interested in syringe drivers.
Great. Thank
Carmen,
you.
can I add one thing to that? As a user, I find just being registered with the Hospice West Auckland training, the training platform. So we get emails, and it's just either small little bits like this webinar is one of those things, but there's also little workshops that you can do, multiple times a year. So for community pharmacy, those are quite helpful as well. And it's not just so much the medicine side of things, it's also the carer side of things that it covers. So we find those very helpful as well, just learning, sharing the learning with you guys.
That's
Definitely,
great to
we
know.
do a lot of training here, and we've got a fantastic L&D learning and development team as well that disseminate these emails. So yeah,
Yeah,
stay in
big shout out
touch.
to them. Next question. What is the general turnaround time for syringe drivers? Can I get Chanel and Sophie to answer that?
Yeah, no problem. So I think, firstly, disclaimer, I can only speak for our pharmacy. Again, it comes down to staff availability and things like that. So for our pharmacy, on a given weekday for, say, just pre-fills, so sometimes patients will start on just pre-fills, we would aim to turn that around in an hour, best case scenario. If there's drivers involved, that pushes it out to about an hour and a half by the time we do all the paperwork, labelling, etc. But I think, correct me if I'm wrong, but I think for pre-fills, we strive for a 1 hour turnaround to get that product to the family as fast as possible. But again, it comes down to communication. So we receive a huge number of things in our inbox every day. If someone doesn't notify us that there's something in the inbox that requires attention and pre-fills or whatever to be made, it can be a bit delayed. So yeah.
And one of the things we find really helps, we've got a really good working relationship with Hospice West Auckland. So they would usually call us and say, this patient is being started, or like one of the nurses would call us. These days, even like Batavia Hospital, they'd call us. This patient would be discharged by 2 o'clock, but it's 11 o'clock now. We can start sending the syringes and you can have it ready. So while the patient is on that home journey, they can stop by the pharmacy and collect the prescription. So that level of communication really helps us. We are able to prioritize our workload in case if like we have somebody else to make beforehand, that sort of thing. So that just a phone call is quite helpful.
Right. Yeah, it's all about planning and communication, isn't it? Great. So I think we've got time for one last question. Can any pharmacy dispense in EMD? Maybe I can answer that one if that's all right. So I guess the short answer is technically yes, any pharmacy can do it. However, this is a process specific to Hospice West Auckland, and our doctors have developed close relationships at this stage with 6 pharmacies in the community, so as to cover the entire region, because when we send all our EMD prescriptions to those particular 6 pharmacies, because they dispense them in the way that we feel comfortable with in our patients, and is aligned to our process and the advice we give to our patients. If you are a community pharmacist or work in a community pharmacy that currently don't dispense EMDs but would be interested, then by all means, we'd be more than glad to hear from you and include you in our whānau of EMD dispensing pharmacies. Either get hold of me or Carmen about that. So that brings us through to the end of the Q&A session. I'll hand it back to Carmen to close off for us.
Just trying to unmute myself. Okay. So remember, there is a lot of special palliative care service here at West Auckland. So please don't hesitate in contacting us. There'll be an evaluation at the end of the webinar for you to fill. Appreciate any feedback you have on what you would like to hear from us in our next webinar topic. To close off, I also really want to thank our panelists, Oleg, Sheena, and Sophie. Thank you for your time. Thank you, L&D team, for setting us up. Couldn't have done it without you. To close off, we'll finish off with a karakia. Turiki whakataha, Turiki whakataha, homie, huie, taikie. Everyone have a blessed day. Thank you and goodbye.